Today I'm going to be talking about digital health. There's some sections on Tim Care um, and some of the other, I guess, digital health system services that are available that you might want to use, might want to consider using, or you might just use it to prompt thought about how to develop your services. This is certainly not a session where I'm trying to sell you a lot of things or anything along those lines. It's more just providing the information based on some of the research we've been doing at the University of Sheffield. So, just to say a little bit about myself, I'm a research fellow from the University of Sheffield. I'm a psychologist by background. I have no medical experience whatsoever. If you cut yourself, I might be able to put a plaster on you correctly. That's about as far as my medical expertise go. Um, Most of my research, or all my research rather, looks at developing healthcare services, mainly for people with motor neuron disease or their carers or health and social care professionals. So this involves a variety of methodologies, a variety of interventions that we have developed or are developing. Um, and although not exclusively, a lot of this work has been through the use of digital technologies, and which is quite fortunate because that's what I'm here to talk to you today about. So just to give a brief overview of what today might look like. First of all, I want to just give an overview of, okay, we're talking about digital health. What exactly does that mean? Um, Discuss some of the technologies and tools that are available, and then those first two sessions largely focusing on clinical care, and then the last two sessions are more focusing on digital tools for research, and then looking into the future that might come later. Time, fantastic. Yeah, right off the bat, I knew this was going to come up. And so, yeah, we can absolutely talk about some of this and how you might think about using digital technologies when time is certainly a huge issue. Remote and rural location is another very interesting one because it's always promoted as something that digital tools might be actually fantastic at supporting. So hopefully I can provide a little information on how it might be able to sort of help. There's certain issues that are specific with working in rather rural locations and access to care, distance travelled. So I hope I can provide a little bit of information on that. On the 10th floor, that's generally quite a specific issue, yes, especially if people with MD are trying to access the 10th floor. And there's slow elevators, and I'm reminded of the hospital in Sheffield, of you're waiting there for quite a while. Right, so I will jump right through to the first um, a couple of slides on this. So this is about trying to find a definition for health or digital health, and then some of the roles that it can function with. So I always get a bit nervous discussing this because it's when you're discussing about digital health and remote monitoring and things like that, you really want to start with something that's like easy to grasp and things like that. And unfortunately, the definition for digital health is just not that. There are a million and one different definitions. I've already used probably about five in this presentation to discuss how you might use some form of technology to support care. And I expect most people on this call will have experience with some or all of them. You will see things like digital health, remote monitoring, telehealth, telemedicine, telerehabilitation, tele anything really, e-health, e-something. It's unbelievably pervasive, the amount of definitions that there are. There is not really an accepted definition. I mean, the World Health Organization have some definitions that are gaining a little bit of traction, but the issue with most of these definitions are that they are very good at explaining what, for example, telemedicine is. And they say, this is what telemedicine is, everything else isn't telemedicine. But they do a very bad description of what then you call everything else. For those reasons, I quite like this sort of framework. It's called Technology Enabled Care Services, or TECS. And I believe it was originally developed by the NHS who were trying to solve some of these issues. And it splits off the different technologies that you might be interested in using, either, for example, as a patient or carer, or you might want to think about using in your clinics. It is certainly not foolproof. For example, during my PhD, I did some research looking at a self-management app using videos for people with COPD. You could easily argue that that falls perfectly in between self-care apps and telecoaching. So by no means is this foolproof, but at least it starts to separate out some of the different things into these various buckets. Regardless of how it's separated out, if you go out and say, right, I'm interested in looking at a digital tool for X, Y, or Z, and you manage to get a list of those available digital tools, they will all have a wide range of names, how they define themselves, what is included. And it's just not very useful, realistically, the definitions that they use. And for that reason, it is often better to ignore what they're called and just focus on what the function of that tool is doing. So if, I don't know, a tool is designed to increase the coordination of care by creating, in this way, a telemedicine or teleconsultation between a specialist M&D consultant and a GP in the community. For example, it's easier just to focus on that function, that linkage of different healthcare professionals, rather than whether or not they call it a teleconsultation, a telemedicine, telehealth, tele anything. So that's probably the first caveat. So I appreciate that I've started with the very first slide saying that here's some digital health definitions, and actually I'm now saying probably don't focus on the digital health definition itself. It's probably likely easier that if you're ever interested in using these tools in your clinic, focusing on the function, and the function that you want is likely a lot easier than focusing on the name of things. In addition to various interventions calling themselves various different things, it by no means is uniform how intensive they are and how engagement is reported. So a digital tool could reasonably define itself as remote monitoring, but in remote monitoring, there could be something where the patient has to do one thing a day, or it could be one thing a week, or a month, or a year. Now, each of those intensities would have different purposes. For motor neuron disease, you would likely argue that remote monitoring once a year is unlikely to be beneficial for what your needs are. Similarly, having a look at some of the research that's conducted around various specific digital health tools, just keep an eye on how engagement is reported. And I'll discuss some of the issues of engagement probably later when we talk about specific interventions. Because again, there's no uniform way to describe how engagement is reported. So you might see 50% of patients engage, and it's not exactly clear what that means. So just wanted to start with this just as a broad overview of definitions. Moving on to the functions of them. So I think this is a lot more helpful. You've got various issues or problems you could probably describe them as that you might want to fix with digital health tools. And it's much easier to go from, right, here's the thing that I want to support or improve. What digital tools are there to do that? So there are a wide range of potential functions. You could probably find a number of digital health tools that are aimed specifically at the thing you want to support or resolve. More often than not, of the research and the technology that I've seen being used in M&D, most of them are about trying to provide more information to the healthcare team from the patient and the carer.
I was just going to say that there was a question about how can digital health platforms facilitate better coordination between the MDT team and caring for patients, neurologists, respiratory therapists, and speech therapists.
So that's a fantastic question. So there are, well, The reason I didn't include a slide on M&D is everyone knows about this. So I feel a bit bad by starting this by saying there are lots of problems or could be lots of problems with coordination. You are probably much more aware of them than I am. So some of the issues that we've looked at are that there are problems with sharing information. So quite a lot of the M&D specialist centres, they link with community teams that are in different NHS organisations. So sharing data with them, finding out who in the community is responsible for what parts of different people's care can also be an issue. Asking the patient who has visited them in the community is not necessarily the best way to go about things because we've heard from a lot of our patients that often there's so many people who visit them, it's hard for them to keep track of who they are, what their role is, who employs them, why they're there. So some of the things that digital health can improve is, for example, maybe making the transference of that information about that patient better, providing a way to support the patient to know who's coming to see them so that when they go to a specialist clinic, they can specifically tell you exactly who has come along and supported them. So we've actually got a study that has just launched in the University of Sheffield called M&D Together. And the whole idea of that is to look at what's going well, what's going wrong with the coordination of care between specialist centres and community teams, and then develop a tool which is not necessarily going to be digital, but based on some of the challenges we know about, is quite possibly going to have a digital component that will hopefully improve that coordination of care. The caveat of that project is that we've just started it. We'll start development of the tool probably in March next year and then start evaluating it. And the project will be finished in around June 2028. So these things are by no means quick, but at least we're aware of some of the issues and there might ultimately be something that we can do to help in that space. I'm hoping that answered some of the questions. So actually, looking at discussing the coordination of care is quite relevant to this. So providing more information to the healthcare team, that could actually be one of the ways that care coordination can be supported. Typically, the idea of this is the hope that by providing more care in between the sort of regular 3 monthly MDT appointments that patients have will provide more proactive care. And so the hope would be that I've sort of thrown up a rough timeline to illustrate this, but if a patient comes to a specialist clinic and then starts to decline, for example, the day after, now naturally there are ways that the healthcare team will be informed, but worst case scenario is that that's not going to be fully picked up for 3 months. Or you've got the exact opposite of that situation where the patient is managing relatively well. There's no significant change in their condition since the last appointment, but they still come to the appointment and there's not much change that can be done to support them further. Now, both of those scenarios are issues in different ways, and it typically results from not having enough information to provide proactive personalized care. It is more set in stone for obvious reasons. But if you had more information, you might be able to adapt to potentially talk to the patient who's managing quite well. Do you need to come in? Is there anything you want to talk to us? Okay, no. Well, we'll put off your appointment for a month. Could be an example. It's not easy to do, but it's an example. Providing early warning of decline is massively standard function of things like remote monitoring, trying to provide objective data of the decline. So this is sometimes seen as moving beyond some of the questionnaires that are commonly used to, for example, could be measuring information generated through an NIV machine. I've got a project that's currently ongoing that I'm discussing later in this PowerPoint. Rarer, I think, in M&D, but certainly not beyond the realms of possibility. There's certainly technology out there. There's tools that could sit on patient records to help with something. So this could be supporting diagnosis if that tool is sitting on GP patient records, for example, or it could be solely a tool that helps, for example, like I said earlier, sharing of information between different NHS organisations to provide easier interprofessional communication. And that could be specific to a patient, or it could be to enable multiple healthcare professionals to access the specialist skills of a specialist centre. I think my takeaway from this is there are a lot of potential functions that you could look at, and it's probably more about identifying what your specific need, your use case is, and then finding the tool that fits that. So I joined briefly each of the groups just to hear how the discussion was going on. Um, and actually, I was wondering whether it would be useful if someone from each of the groups wouldn't mind just briefly summarising some of the things they discussed about, some of the things that they might think might change if you've got potentially more information in between clinical appointments and things like that. So
Yeah, we were broadly enthusiastic. We talked about the TIM pathway, but I think you're going to probably cover that later, aren't you, Liam? So I did pop it in the chat, and we thought it'd be very useful to get the information around things like weight loss between visits so that you could prepare better and make sure the right people were at the MDT to help provide continuity of care or bring people in early, or as you said, Liam, if there was no change, to tell someone they don't need to come in and waste their own time, or the difficulties people have of getting to our care centres. We felt that the system would always need an early warning sign of decline and some kind of red flag system, and it would need to be someone's responsibility in the MDT to monitor it, because there are so many people involved, whose job it would be to monitor whatever system we had. I think that was about it for my group.
That sounds great. Yeah, certainly we're always aware that if someone has M&D, they don't have all the time in the world. So if you can limit how much that they're spending on, for example, maybe going to an appointment that might not be necessary, because it's not just the appointment itself. If you've got massive fatigue, we've had some patients who discuss that essentially it takes them a week, sort of maybe a bit before, a bit after, to recover from each of that appointment. Now, a week's a huge amount of time if you've got MND. So I think any tool that can be used, or it doesn't have to be digital, it's just thinking about if we can minimize those potentially unnecessary appointments. I think that would always be a huge win for patients and carers.
I know our group, I think we thought it would help to prioritise, particularly most of our group were working in community settings, some in really rural areas. So if you had 2 patients and you were trying to juggle who to visit with a 3-hour journey, then it might help to prioritise with having a little bit of objective information beforehand as to who to go and visit first. We thought families might be helpful in helping with the data input on that, because we were wondering about whether every patient would engage with a system like this. I'm sure you'll talk about this, Liam. And I guess, yeah, another downside perhaps of this might just be constantly, if it looked at lots of different areas of function, would that actually just be quite a depressing thing for people to be regularly recording that? And so we'd like to be kind of targeted by looking at a specific symptom, perhaps that is a worry, say secretions or something like that, so that we're not looking at how everything's deteriorating all the time.
So there's certainly important considerations. I'll actually hold off on some of that just because I'll mention it in about a slide time if that's okay. But yeah, thank you very much for the discussion.
We were just saying a couple of us get a lot of feedback via text message, so to have something like an app to be able to feedback, but there is obviously the downside of, are we getting the full patient information? Are they telling us what we want to hear? So it's having that in mind, as well as being able to get relatives to be able to feedback. It's obviously accessing a device if hand function is deteriorating. So we've got really great ideas in terms of having something digital to be able to feedback from a page. How we do that in practice was another thing. So looking at it in sort of a hybrid way, so still obviously having that patient face-to-face contact, but the feedback that we get on, say, if it was a text message, an app, anything sort of digital, for the MDT to be able to see as a whole, so that everybody could see the feedback. Richard was saying, obviously, his side of things from the physio, I think Richard said, is that right, Richard? And then I'm speech therapy. So if we had that information and a few different MDT members would be able to see that information, it would make it a lot smoother for us all to kind of come from the same place. That was the sort of discussion we were having.
That is fantastic, because that, I believe, also leads us on to the next thing to discuss, which is some of the current technologies that either we've used in Sheffield or have been developed slightly wider. So some of the people, I'm sure, are aware of this already. I know Tara and Sean from Sheffield are on this call, and you've heard me talk about TimCare for no end. So this is a tool that has been developed in the University of Sheffield alongside Sheffield Teaching Hospitals. As I mentioned earlier, there's lots of different names that we can call things. We're by no means any better than the rest of them. We've called ourselves telehealth, which means everything and nothing, like I said earlier. The general aim of this system, this service, is to provide more responsive care, is ultimately what its function is trying to do. How that happens is that people with MND and their informal carers can be invited to TimCare. They will then, obviously, if they say yes, they'll then complete regular questionnaires that the information gets securely sent to their healthcare professional team, who can then review it and make any decisions needed, potentially providing advice. I've included a couple of images. So the top right image is just an example of how a patient might answer a specific questionnaire. This is from the breathing questionnaire. Others, quite commonly, something like the LSR, which is pervasive in MND care and research. They'll have multiple options per page. They click one, move on, click one and move on, and then submit at the end. How it's presented to the healthcare professional side, so this is through their own clinical portal. You can review either a sort of brief snapshot for lots of patients at the same time and then potentially prioritize who you want to review, or you can go into specific patient accounts, specific data, and look at a lot of data for that specific patient or carer. And so these are some of the things with graphs. And if you found sort of any of these squares interesting, you thought, oh, there's quite a dip, you can click on that little box and it will bring you up all of them. It will show you what's changed since the last time you've completed it. For patients and carers, they can either download an app or they can log in using any web browser, any internet connected device. Our research suggests that about there's a 50-50% split between downloading the app or online. And for healthcare professionals, it's just online using passwords and usernames specific to each individual. What we've found is that, so I should have said that the questionnaires get sent out every 2 weeks. And most people's gut reaction to this is, oh, that's quite a lot. Are patients going to engage with it? What we've found is the answer is generally yes. About 85% of these questionnaires are completed that are sent out. Patients are also reporting, and healthcare professionals are also reporting, that it's relatively easy to use, it's low burden, you can log in when you want, you receive an email saying you've got some new questionnaires, you can ignore it for a couple of days when you've got a spare 10-15 minutes and then complete it then. How it's used from the healthcare professional side is actually rather flexible, and we've got a couple of use cases now that use it all slightly differently. Now, I will admit, when we started this, we didn't anticipate that at all. So from the patient side of things, we do have a select cohort that, despite the fact that the questionnaires come every 2 weeks, they might complete some, ignore them for about 3 months, and then start completing them again because they feel like they've got a change that they wanted to report. We had no idea that this would be something that would happen. We just saw it in the data. And actually, if patients want to use it that way rather than completing the regular questionnaires, there's no reason why they can't. From the healthcare professional side, what we've traditionally done in Sheffield, although we are changing how we use it, is that the idea would be that someone would regularly monitor the questions or the answers, sorry, that are coming through every sort of 2 weeks or so, and then escalating out to the wider MDT. However, we've also got other services who essentially use it the opposite way, where individual members of the MDT will look at specific answers. So the respiratory physio might look at the specific breathing questionnaire, a clinical psychologist might look at just the mood questionnaires, and so on and so forth. And then they might discuss it at an MDT. How we're potentially moving to using it in Sheffield is more to facilitate clinical appointments. And so this would be Joe Bloggs comes in, you can see some of the problems that they've been having since you've last seen them because they've completed the questionnaires. And then you can spend that limited time in an appointment specifically answering their problems rather than trying to gain some of the information and then trying to answer them all in one appointment. As was mentioned in some of the breakout rooms, by no means will I argue that this system is foolproof. One of the useful things with this system is it's not fixed. So actually what we do with a lot of the services that currently use it is we tell them if there's something that you'd like changed, let us know. We can't promise that it'll change overnight, but it will certainly will look at it and do what we can.
Does this interaction change as parents rely on carers to complete it? Sorry,
So
patients.
it certainly can. So that what the research that we've done on the system is telling us is that the system can be used by patients even with quite significant levels of progression of their MND, but naturally there is a point where they won't be able to use it. And what that generally typically occurs at that point is naturally the carer will take over and answer on their behalf. What we're finding is it's the similar type thing. At that point, largely you're operating at clinical appointments where the patient and care are sort of essentially acting as a dyad, and you're organising care with the support of both of them. So actually, anyone answering those questionnaires is quite beneficial because again, it can still provide information to be used in clinical care. It's, I think, less important. No, sorry, I do think it's important who completes it, but getting that information, any extra information is always going to be a benefit. Some of the things we found during COVID, because the system is also available for carers, is that it gave them an opportunity, a forum to answer honestly some of the things that were bothering them. So the carers received questionnaires on mood and carer strain. And when you've only got 15 minutes for a face-to-face clinical appointment, the last thing the carer wanted to do was mention that they have X, Y, or Z going on and they're struggling. They don't want to take time away from the patient. So the things that kept being said was it's given me the opportunity to gain back my voice, and have an opportunity to report some of the things that might be problematic. Some of the uses, I guess, one further use of TimCare is that, as was mentioned during one of the workshops, if you have a system where multiple people can review it at the same time, it means that the patient's not having to repeat themselves lots and lots of times. So, for example, MDTs with lots of healthcare professionals, they could be spread over a wide geographical area, Zoom meeting to discuss a specific patient. If everyone has TimCare up on the specific patient, they can grab some of the information that they need right there and then. So it's something that we've been using in Sheffield a while, and it's been slowly expanding to various other care centres over the last several years. But it's something that I think it's fair to say we're quite proud of it. It's been going on a fair long while, but it's certainly something that we're keen to keep developing based on feedback we received. And I wanted to just briefly mention sort of other things that exist. Certainly, like TimCare is not the be all and end all of remote monitoring or digital care. There are other things that are slowly getting used more and more. So it's some of the things like wearable biomarkers. So Actigraph is being used primarily in research at the moment, but there's some suggestions for it to be used in clinical care. This is a tool that, as I was mentioning earlier during the functions, is trying to objectively capture digital biomarkers of movement and how much movement that specific patient has. The image of the little fingers with the arrows is the best one I could find of this. It's a system that's been developed in Dublin that essentially is trying to measure hand strength and grip strength or finger movement. It's a terrible image to display that, but it's literally the best one I could find. And again, it's trying to give either the researcher or the healthcare professional an objective marker of this and how it might have changed. And then also there's more often seen in things like respiratory conditions. COPD actually has a fair amount of these, whether they're used widely or not. There's a fair amount of these, certainly in research, is respiratory monitors or breathing monitors. They can either strap on or wear as pendants. They can monitor cough sounds sometimes, and there's work trying to go on about attaching all of these tools to a meaningful outcome. So, for example, if an actigraph says that someone has moved 0.1 less today, is that clinically relevant? Is it relevant to the patient? So there's still work that needs to be done to determine that real world impact. These tools are remarkably useful for objective measurements, but that's the link that's needed before I think they will be more widely used in healthcare. So we've talked about TimCare. I've given a brief overview of that. That is being used in various specialist centres around the UK. Tim Research, or TimR, is inventively named because it is the research arm of TimCare. The difference with TimR that it can be used by anyone in the UK with MND. You don't have to be attached to a centre using TimCare. Anyone can join, regardless of where they live, from the bottom of Plymouth all the way up to Aberdeen's quite far north. So anywhere in between, they can join. It's essentially rather easy to join. So if you go to the UK MND-RI website, which is the UK MND Research Institute website, click Get Involved. There's information there for patients and for researchers, and they can click Sign Up. It follows a similar format to TimCare, but this is a sort of overview of what we see it being used as. So they can join if they're on TimCare, that's absolutely fine. If they're not, that's absolutely fine too. Once they're involved, they will receive invitations to research projects that they might be eligible for. They'll receive research news from around the world. It doesn't have to be studies that they're involved in. It could be anything that we might think they're interested in. And they'll also have the opportunity to complete questionnaires that are then linked with things like the MND register. And then future researchers can look at it to find interesting patterns and things that ultimately might speed up the search for a cure. That's sort of the broad overview of what TimR is. And this is how we see it being used. So it's been launched just a little over a year ago now. And we have approximately above over 100 people using it, but we're very keen on expanding that further. The whole point is that you should not have to live near a specialist centre or indeed a research site just to engage in research. There's a lot of activities that can be done online or remotely. We're not completely naive. There are some studies that need to be done in person. If you're giving someone a drug for the very first time, you're likely going to want to have them in a clinic with trained people around them. You wouldn't do that remotely. But there's certainly a number of things like providing people questionnaires, interviews, even biosampling. You don't have to have the person there. You're saving time. Why not do it? A brief slide on the benefits and challenges. So whereas various research studies that are going on in MND have extremely exclusive eligibility criteria, TimR doesn't. It's literally, do you have MND? If yes, you can join. Anyone in the UK, absolutely eligible. All you need is an NHS number or the Scottish or Northern Ireland equivalent of an NHS number and an email address, and you can join. And because we're asking quite a few questionnaires for patients to complete, they don't have to complete them, they are all voluntary. But if they do complete them, they're approximately every 2 months. It's fast becoming one of the largest databases for this data in the world. So, like I said, been going slightly over a year. We have way over now 3,500 of these completed. And that's such a huge pool of data that's unbelievably useful to identify trends, associations, anything. Remarkably happy with the amount of engagement that's happened already. However, some of the things we have heard back is you are asking patients to complete every 2 months a series of questionnaires, and they're answering the exact same questionnaires. Now, that's the benefit, that they're answering the same things for a researcher, but they can be repetitive. If you're getting asked the same question every 2 months again and again and again, it can be repetitive. So there's some solutions that you could think to this. So it could be sort of creating adaptive surveys. So for example, one of the solutions that I might not recommend, but you could ask, have you had any changes since the last time you completed a questionnaire? No, fantastic, you're done. If yes, which would you like to provide updates for? So that's some of the things that can be done. There's reasons why you may or may not want to do that, but they're options. And some of what I've discussed already. Some studies need to be done in person, absolutely. But even those studies, you can think about doing hybrid methods. So if you're giving someone a drug and they need to come in at the 3 month mark to, I don't know, give some blood and answer some questionnaires, post them the blood kit, answer the questionnaires online. You've saved that patient a week from going to the appointment and recovering afterwards. And so last slide, just looking forward. So this is more clinical care and potentially research. Some of the systems that are coming out or being developed largely focusing on predicting when a certain outcome is going to happen. So for example, when am I going to need a PEG? When am I going to need NIV? And so there's a study again going on in Sheffield. But PACE MND is trying to do this, trying to understand, can we predict reliably when certain interventions are going to be needed? I mentioned earlier a potential use case or function of technology could be to sit on patient records and highlight when it might be MND based on SNOMED codes and things like this. This is something we're doing at the moment called MND Alerts, and it's trying to prompt GPs to refer to neurology as opposed to the standard diagnosis route that goes potentially a couple red herrings and currently around a year delay. And then the big one that everyone keeps talking about at the moment is artificial intelligence. It is likely that this is going to become bigger and bigger and bigger. It is growing. However, I do not currently know of a fantastic use case that uses it already for MND. I expect it will be ultimately extremely useful, but maybe not right now. The problem with AI in itself is that it can be fantastic at identifying patterns between various bits of data. It is currently not very good at saying why those patterns are important and telling the healthcare professional sort of why they should care about the pattern. It just says, patient said this might mean later X, Y, and Z. And finding that out and expanding on those can be difficult. The XAI, so the expandable AI, is trying to overcome that limitation. So trying to provide explanations of, based on this model, I think X has happened and X, Y, Z is going to happen later. It's trying to be better explaining that process, so opening up that black box. We're not quite there yet, I don't think.
What are the main barriers to adoption of remote monitoring technologies for MND patients, particularly for those in rural areas or with limited technical support? Now, I think you've kind of covered that earlier with your example.
Yeah, a little. It's probably more an automatic assumption from a who might be skeptical over technology, thinking that they can't use it, or will it replace their clinical care? There's certainly some barriers from the healthcare side as well. With all the goodwill in the world, there's the often pervasive example of our older generation can't use technology. I personally believe that is absolute rubbish. There's so little evidence to support that statement, that people who are older can't use technology for healthcare. The evidence that's largely not done in the UK suggests that my gran might not be able to use Facebook, okay, but by all means, she can Google her symptoms and come up with 1,000,001 diagnoses. Like that happens a lot. So it's more that overcoming those limitations that are sometimes gatekeeping. You don't want to suggest it to a patient because you think they might not get on with it, and then you talk to them and they're absolutely fine. And I appreciate those gatekeeping can be done with the best will in the world, but I'm a big advocate for providing patients all the choice, regardless of whether you think they're going to say yes. It is up to them to say yes or no to a particular tool that they might want to use. So there are probably a couple of the barriers that exist, and I guess the flip side of that, the facilitators, is just giving patients the options, explaining to them that actually it's not that hard. The rural side of things, some of the tools I've discussed today are actually remarkably sort of low tolerance on anything like Wi-Fi or things, so that is less of an issue. I mean, don't get me wrong, if someone doesn't have Wi-Fi at all, they don't have a phone, they don't have a computer, that's an issue for using something like TimCare. But outside of that use case, actually, there's quite a lot. It's less of a problem than sometimes you might think, I guess.
That's great. Thank you, Liam.